Good evening, everyone. Myself, PRIYADHARSHINI LOGANATHAN, working as a professor in Excel College of Physiotherapy and Research Center, Komarapalayam. Today, I am going to discuss about neurology for grade 2 physiotherapy and MRB examination. Let me go for this question session. First question, which of the following is not the primary germ cell layer? Option A, ectoderm. Option B, mesoderm. Option C, endoderm. Option D, epiderm. So, or guess the answer. Shall we discuss the options? Ectoderm is a outer layer, mesoderm is a middle layer, and endoderm is a inner layer. Okay. So once the zygote formed, the embryonic yolk sac developed into 3 important germ layer. So that is ectoderm. So this, you imagine it is a outer layer, ectoderm. This is a middle layer, and this is a inner layer, endoderm. Okay. So ectoderm developed as a neuronal plate, and it is developed as a groove and developed as a tube, neuronal tube. If any deficit in neuronal tube development, it is a disease. We call it as a spinal bifida. Okay. So this mesoderm, it is a middle layer. It developed as a vital organs or inner organs of our body. The endoderm developed as a bone, cartilage, and ligaments. The answer is epiderm. So epiderm is an odd one. So ectoderm and mesoderm and endoderm is a 3 main important germ layer. Next question. Next one, proprioceptive sensation as in spinal cord through option A, posterior column, option B, lateral column, option C, anterior column, option D, anterolateral column. Guess the answer. Shall we discuss the options? I think எல்லாத்துக்கும் தெரியும். This is a cross section of spinal cord. Yes. So this is a cross section. This is gray matter. Center portion is gray matter. This is white matter. This is a posterior column. Posterior. This one is anterior. And this one is lateral. So come to the point. The posterior column is responsible for discriminative sense and proprioception and vibration. Yeah. And lateral is responsible for pain and temperature. Anterior is responsible for crude touch and pressure. Okay. Our question is proprioceptive sensation as in spinal cord through. So the answer is posterior column. Next one. Meissner's corpuscle is for option A, 2-point discrimination, option B, touch, option C, temperature, Option D, pressure. Guess the answer. Let me discuss. So, Meissner's corpuscle, it is a receptor present in our skin. See, as we know, எல்லாத்துக்கும் தெரியும், in our skin we have a different type of receptors, which mean touch, we have a receptor that we call it as a Merkel. Temperature, we have a thermoreceptor. Pressure, we have a mechanoreceptor. So the 2-point discrimination is a tactile sense. So that is called as Meissner's corpuscles, which means it is discovered by the Meissner's, the scientist. What is the corpuscle? It's simply the myelin sheath covered by a swan cell is covered by a myelin sheath. Okay, so the Meissner's corpuscle is responsible receptor for 2-point discrimination. Okay, the answer is two-point discrimination. Next, fourth one, which of the following statement is true about decerebrate rigidity refers to? As we know, once the patient had a higher level or a nervous system lesion, the patient underwent a decerebrate or decorticate posture. So the options are sustained contraction, posturing of the trunk and limbs in a position of full flexion. Option B, sustained contraction and posturing of the trunk and limbs in a position of full extension. C, sustained contraction and posturing of the trunk and upper limbs in flexion and lower limb in extension. Option D, sustained contraction and posturing of the trunk and upper limb in extension and lower limb in flexion. Guess the answer. So let me discuss. After central nervous system lesion due to traumatic brain injury or stroke, whether it may be a vascular pathology, the patient entered the two posture. One is decerebrate. So what does the decerebrate means? If the patient is both upper and lower limb in a extension position. So and another terminology is decorticate. What is decorticate? The upper limb look like a flexion posture and lower limb into extension. That is a two term. So kindly remember that central nervous system lesion அப்படினாவே நம்ம decerebrate and decorticate. So அதோட presentation மட்டும் தெரிஞ்சா போதும். So here the option, the correct answer is sustained contraction posturing of the trunk and limb in a position of full extension. Yes, it's a correct answer. Next question, fifth one, which is not a feature of Myasthenia gravis? Option A, muscle weakness. Option B, muscle wasting. Option C, muscle fatigability. D, option D is a fasciculation. Guess the answer. So let me have a clear explanation of the myasthenia gravis. It is autoimmune disorder. What is autoimmune? Abdina, number antigene or edri ulla vanditangan soltu or antibody produce pannu. So that is a myasthenia gravis. The gravis means a weakness. Myasthenia gravis is a neuromuscular junction anomaly. Simply, you just think it. So this is a presynaptic nerve endings. This is postsynaptic. So here is a acetylcholine, here in a receptor. In presynaptic, it is banded with a vesicle. Here is a postsynaptic nerve endings. Here we have a receptor site. What actually happened in myasthenia gravis? Our body itself thinks this is a enemy. The receptor site is the enemy. Consider like this, that acetylcholine is not come and bind with the receptor site. What actually happened means this is not enter, which means entered. That is a calcium ion is important for a muscle contraction. Okay, so if this antibody will close the binding site, what actually happened? The calcium ion is not transmitted to this postsynaptic nerve endings. That leads to weakness, fatigability, and fasciculation. Okay, so what is the answer is, which is not a feature of myasthenia gravis? That we have answer. Muscle wasting. Next question. The EMG activity of denervation or the following except. The option A, fibrillation potential. Option B, positive sharp wave. Option C, polyphasic action potential. Option D, all of the above. Guess the answer. So let me discuss the options. So EMG is the electrical activity of muscle is graph in electrical activity is measured in a graph. So the denervated muscle have that different potential in a graph. Okay, so the fibrillation potential means we just take it as a graph. Yes, that is small duration, short amplitude of waves we see in it in this fibrillation potential, and positive short waves, the wave always to be in very short in length. Yes, the polyphasic action potential is normal function of EMG. This is a innervated muscle function, and D is a all of the above. The first, we check it. Polyphasic action potential. It is a normal action. That is a normal innervation of muscle function. Next question. Ipsilateral paralysis and dorsal column interruption with contralateral loss of pain and temperature. Options A, option C, Brown-Sequard syndrome, option B, conus medullaris lesion. Guess the answer. So let me discuss the options. The option A, central cord syndrome. It is a type of spinal cord injury. It is typically a hyperextension injury. Central cord syndrome. What is the common features? What are the signs and symptoms present in central cord is sensory anterior cord syndrome. And Brown-Sequard syndrome, it's simply a hemisection of spinal cord is affected. So the presentation is paralysis. It is same side paralysis and opposite side pain and temperature sense will change. The conus medullaris is a lower cord syndrome. Yes, the answer is Brown-Sequard syndrome. Next question. All of the following statements are true about tendon reflexes except options. A, the stretch of muscle spindle. A, the stretch of muscle spindle. Option B, activation of spindle efferent. Option C, monosynaptic projection to alpha motor neuron. Option D, non-projecting gamma motor neuron. Guess the answer. Let me discuss the options. Option A, stretch of muscle spindle. What is muscle spindle? It is a receptor which is present in the muscle to feel the stretch sense. Okay, once the muscle spindle have a stretched, so that the efferent fibers will activated in that muscle spindle, and it is entered to this posterior horn cell of spinal cord, and it come down as a corticospinal tract. So it convey have to this anterior horn to this intraneuron, and it will project this monosynaptic projection to this alpha motor neuron. Okay, so this is a chain. It is a reflex mechanism. First, the muscle spindle will have a stretch sense. Once it is stretched, the efferent information will take the way, and it is taken to this posterior horn and perceived in a higher center, and projection to this interneuron, to this alpha motor neuron, to this corresponding muscle. So option D is a non-projecting gamma motor neuron. It is a non-projecting is not a correct answer. Okay, so except, the question is except all of the following statements. These all statements are correct to a normal tendon reflex. The option D is a odd one, non-projecting gamma motor neuron. So the answer is non-projecting gamma motor neuron. Next question. The feature of autonomic dysreflexia. The feature of autonomic dysreflexia are option A, tachycardia, hypertension, headache. Option B, bradycardia, hypertension, headache. And option C, pallor, tachycardia, headache. Option C, all of the above. Guess the answer. See, let me discuss the options. Tachycardia, hypertension, and headache. It is atrial fibrillation and some other systemic complications. We discussed about the B, the bradycardia, hypertension, and headache. We just discussed about the autonomic dysreflexia. It is a symptoms of spinal cord injury. What actually happened? What is the pathophysiology behind this autonomic dysreflexia? Means the sympathetic ganglion above the cervical and thoracic. Like cervical and thoracic level spinal cord injury, what actually happened? That the sympathetic ganglion will regulate the heart rate and blood pressure. So if that the cervical and thoracic level sympathetic ganglion will affect it, so the symptom to be first pounding headache. Yes, the headache is the first symptoms of autonomic dysreflexia. It is pounding. So தலை வந்து அப்படியே குத்திட்டு இருக்க மாதிரி இருக்கும், அடிக்கிற மாதிரி. So hypertension, pressure அதிகமா இருக்கும், and bradycardia. So option C is a pallor tachycardia headache. So ஒரு மாதிரி வெளிரி போன மாதிரி இருப்பாங்க, heart rate அதிகமா இருக்கும், கூட தலைவலியும் இருக்கிற மாதிரி இருக்கும். Option C, all of the above. The feature of autonomic dysreflexia or, we check the answer. Bradycardia, hypertension, and headache. It is simply a autonomic reflex. This is a sympathetic ganglion is involved. So next question. Which of the below mentioned primitive reflexes is more disabling for the transition from supine to sitting? Option A, ATNR. Option B, STNR. Option C, TLR, that is a tonic labyrinthine reflex, and option D is a Moro reflex. Guess the answer. So let me discuss the options. ATNR, asymmetrical tonic neck reflexes. STNR, symmetrical tonic neck reflex. Labyrinthine, so it is a Moro or statal reflex. So these are all primitive reflexes. Okay. So what is that use of the primitive reflexes? According to this reflex theory, motor learning and motor control. Theory, motor learning and motor control is achieved by primitive reflexes. Okay. So what is the asymmetry? So asymmetry அப்படினா எல்லாத்துக்கும் தெரியும். So இப்போ baby head வந்து turn பண்ணிருந்துச்சு அப்படினா, it is a left side. The turn side extension opposite side, that is right side flexion ல இருக்கும். So that is a asymmetrical tonic neck reflexes. Symmetrical அப்படினா we have that similar. So if the baby is flex the neck அப்படினா, so upper limb எல்லாம் அப்படியே flexionலயும், lower limb எல்லாம் extensionலயும் இருக்கும். So extend அப்படினா head is extended அப்படினா the upper limb is extended and lower limb is flexed. So what is the role of this STNR means? It is otherwise called as, this otherwise called, what we have to call it as? We otherwise called crawling reflex. It is otherwise called crawling. ஒரு குழந்தை தவழணும் அப்படின்னா கண்டிப்பா இந்த ரிஃப்ளெக்ஸ் வந்து ரொம்ப இம்பார்ட்டன்ட். ஸோ அடுத்து நெக்ஸ்ட் TLR, it is a labyrinthine. It is simply a posture and balance in that space. அதுதான் labyrinthine reflection சொல்லுவாங்க. Moro, it simply ஏதாவது ஒரு சவுண்ட் கொடுத்தோன்னே பேபி என்ன பண்ணும்? abduct and adduct. Yes, abduct பண்ணிட்டு that will up and adduct. Okay, it is at Moro reflex. So the question is, which of the following mentioned the primitive reflexes is more disabling for transition from supine to sitting. Supine la irundha அப்படியே sitting position போறதுக்கு எது ஹெல்ப்பா இருக்கும்? You just think it. இப்ப symmetrical tonic neck reflexes அப்படின்னு பாத்தீங்கன்னா that will helpful for a rolling. But STNR it's a sudden என்ன ஆகும்? Flexion or extension போகும். அப்போ if the primitive reflexes persistent ரொம்ப நாளுக்கு இருந்துட்டே இருந்ததா that we have call it as a pathological reflexes. So that is the answer is STNR. The answer is STNR. Symmetrical tonic neck reflexes. Next question. Writing is. So the writing is option A, midbrain reaction. Option B, cortical reaction. Option C, cerebellar reaction. Option D, none of the above. So have a look at. So let me discuss the options. Writing is a reaction. It is advanced type of postural or movement development for newborn baby. So writing is simply what is the writing means? Simply head on body. Yes. So how the head get a stimulus from two different parts. One is vision. See, the baby will develop ஒரு குழந்தை the head on body அது எப்படி டெவலப் பண்ணிக்கும் அப்படின்னா ஃபர்ஸ்ட் விஷன் அது டிரான்ஸ்வர்ஸ் மூவ்மெண்ட் அண்ட் மூவ்மெண்ட் ஆஃப் ஐல ஒரு டிஃப்ரெண்டான ஆப்ஜெக்ட்ஸ் எல்லாம் பார்க்குது. ஸோ அது பார்க்கறதுக்காக தட் டேர்ன் the head on a body. Yes. And it will get it up and downward movement of head through this vestibular reaction. So these are all, that is the ability to distinguish the head on body or body on body. In the reactions வந்து control பண்றது என்னென்ன systems அப்படின்றத பார்க்குறோம். So midbrain reaction one is, so midbrain is a correct answer. How it means, so the head and the body orientation is controlled by this midbrain. And cortical reaction is otherwise called as equilibrium reaction. So what does that equilibrium means? First one, the midbrain will control the head on body, and this equilibrium is the extremity in space. So if we move that extremity, how in space, that is controlled by a cortical reaction. So the cerebellar is an advanced movement science, and option D is a none of the above. The correct answer is so the midbrain reaction. See, we have to rule out all the reflexes. So which center is regulated? That the spinal have a certain reflexes, and midbrain and brain, that is a brainstem, and cerebellar or cortical. Next question. Stalking and claw sensory loss is observed in option A, diabetes, option B, GBS, option C, chronic inflammatory demyelinating polyneuropathy, option D, all of the above. Guess the answer. So let me discuss the option. The option B is the diabetes. So diabetes is a metabolic disorder. So என்ன நடக்கும் அப்படின்னா impaired glucose tolerance. So impaired glucose tolerance நால blood vessel to nerve. So impaired glucose tolerance more than that 10-15 years ஒருத்தருக்கு diabetic இருக்கு அப்படின்னா secondary complication. So diabetic neuropathy சொல்லுவோம். So impaired glucose tolerance vesselல particularly this nerve supply பண்ற வெசல்ல impaired glucose tolerance இருந்துச்சு அப்படின்னா the nerve ஓட caliper அதோட thickness size வந்து loss ஆயிருக்கும். So இப்போ loss ஆறனால என்ன இருக்கும்? Neuronal symptoms. So simply neuropathy symptoms என்னென்ன இருக்கும் அப்படின்னா that we know that paresthesia. So what is the term paresthesia is altered sensation. So என்னெல்லாம் இருக்கலாம்? Tingling, pain and numbness. Okay. So diabetes, it is a metabolic disorder. So impaired glucose tolerance, the blood vessel that will supply to the nerve. So due to this impaired glucose tolerance, that is a proper blood circulation சரியா nerve இருக்காது. So அதனால அதோட caliper loss ஆகறனால they have a symptoms of paresthesia, that is altered sensation. என்ன வேணாலும் இருக்கலாம், tingling, pain and numbness. So it is next option is Guillain-Barré. I think we are know that post infectious polyneuropathy அப்படின்னு சொல்லுவோம். அதாவது ஒரு வைரல் இன்ஃபெக்ஷன் வந்ததுக்கு அப்புறம் ஸோ அந்த பெரிஃபரல் நர்வ் வந்து செக்மெண்டல் டீமைலினேஷன் அந்த மாதிரி இருக்கலாம். இட் இஸ் அ லோவர் மோட்டார் நியூரான். சேம் நியூரோபதி சிம்டம்ஸ் தான் இருக்கும். பாராஸ்தீசியா, டிங்லிங், பெயின் அண்ட் நம்னஸ் இருக்கும். ஸோ நெக்ஸ்ட் ஆப்ஷன் இஸ் chronic inflammatory demyelinating polyneuropathy. The name itself demyelination of peripheral nerves. Same என்ன இருக்கும்? பாலி நியூரோபத்தியோட சிம்டம்ஸ் இருக்கும். ஸோ அது எப்படி இந்த சிம்டம்ஸ் ப்ரெசென்டா இருக்கும் அப்படின்னா ஸ்டாக்கிங் அண்ட் கிளவ். வாட் இஸ் த ஸ்டாக்கிங்? ஸோ காலுக்கு நம்ம எப்படி சாக்ஸ்லாம் போடுவோம்ல அந்த மாதிரி அந்த ஃபுட் எக்ஸ்ட்ரீமிட்டிஸ், தட் இஸ் அ பெரிஃபரி, ரிஸ்ட், தட் இஸ் அ ஹேண்ட் அண்ட் ஃபீட். ஸோ இதுல எல்லாம் எப்படி இருக்கும்னா இந்த பாராஸ்தீசியா, tingling, pain and numbness sensation இருக்கும். Okay, so we check the answer. So all of the above. Yes, we discussed diabetes also have a neuropathic symptoms. GBS also have a diabetic same like neuropathic symptoms, and CIDPN also have a neuropathic symptoms. Hemiplegia occurs when lesion in option A above pontine, option B at the level of pontine, option C below pontine, option D none of the above. Guess the answer. So let me discuss the options in detail. First, we have to know about the crossed hemiplegia. அப்படின்னா என்ன தெரியும்? ஸோ நம்ம எல்லாத்துக்குமே தெரியும் hemiparesis அப்படின்னா half side of face and right or right and lower extremity and right upper extremity வந்து paresis இருக்கும். ஓகேவா? So what is the cross means? Simply facial weakness. இப்போ எக்ஸாம்பிள் ரைட் சைடு facial weakness இருக்கு அப்படின்னா left side hemiparesis இருக்கும். That is the crossed. What is cross means? The facial weakness வந்து ipsilateral facial weaknessம் contralateral hemiparesis or hemiplegia இருக்கும். So what is the pathology or what is that pathway? எதனால இந்த crossed hemiplegia chances இருக்கு, இல்ல எந்த இடத்துல involve ஆச்சு அப்படின்னா லைக் பாண்டைன்ல பான்ஸ்க்கு மேலையா இல்ல at the level of பான்ஸா பிலோ பான்ஸா அப்படின்னு பார்க்கணும். ஸோ யூ ஜஸ்ட் கன்சிடர் இட் இஸ் அ cerebral hemisphere right and left. So it is a brain stem. அந்த இடத்துல நீங்க yes. So any space occupying lesion at the level of ponsல இருந்துச்சு அப்படின்னா that will involve the same side obturator nerve, oculomotor, abduction and facial nerve. So facial nerve மூணுமே paralysis ஆயிருக்கும். So that is a crossed hemiplegia. Yes. So answer is of pons. Next, key point control or described in which approach? The option A, the brainstorm. Option D, roots. Let me have a look. Discuss the option. Brainstorm, Bobath, North, was and Roots. These are all neuroscientists or neurophysician. They discovered approach or relearning technique so these are all neurophysician or neuroscientists. Okay, so they discovered certain approach and techniques. The Brainstorm, she discovered that approach, which means the recovery after stroke. So what is the extremity presentation after stroke? So she categorized a 6 stage of stroke. So recovery after stroke. Option B is a Bobath and Carol Bobath, Beta Bobath. He discovered this neurodevelopmental therapy. So there he discovered 2 important techniques. One is key point control, another one is handling and normalizing tone also. So what is key point control in CP, cerebral palsy baby? To achieve a upper limb movement, we have to stabilize the scapula. So here the scapula is a key point. To achieve ambulation, we make a baby to walk. The pelvis is a key point. Yes. So handling also, to first we have to search about the normal pattern of movement. So for that we handle a CP baby. So the key point control is it is discussed about by the Bobath. Next scientist, it is a neurophysician, North and Was. They discovered a PNF. So I think we are very aware of that PNF, that is a proprioceptive neuromuscular facilitation. We incorporate the different facilitatory technique, thereby we achieve a motor control. Okay, this is not a key point control. And Roots is a scientist, neurophysician and neuroscientist. He discovered to achieve a motor control through sensory stimulation. Through this ontogenic reflex pattern. What is ontogenic reflex pattern? Simply supine withdrawal. நம்ம எல்லாத்துக்கும் தெரியும், பிறந்த குழந்தை ஃபர்ஸ்ட் எப்படி இருக்கும், சுப்பைன்ல கை காலெல்லாம் ஆட்டிட்டு இருக்கும், அதுக்கப்புறம் ரோல். ஸோ ப்ரோன் பொசிஷன், ப்ரோன் ஆன் எல்போ அண்ட் ப்ரோன் ஆன் ஹேண்ட். ஸோ அதுக்கப்புறம் குவாட்ரப்போ. ஸோ த ரூட்ஸ் வில் டிஸ்கவர்ட் அபவுட் த autogenic developmental pattern. Through that stimulate the sensation, we achieve a motor control. Regarding this question, the key point control are described in, we check the answer, Bobath. Next question, 15th question, grid maneuver is when there is the option A, automatic bladder, option B, autonomous bladder, option C, detrusor sphincter, option D, flaccid sphincter and spastic detrusor muscles. Take a while. So we discuss the option. So the grid maneuver is a technique. Okay, when we use a technique. So in spinal cord injury, say the grid maneuver is nothing but we facilitate the voiding of urine. Simply we facilitate the micturition. Okay. So in spinal cord injury, especially the micturition center is present in S2 to S3 or S4 in the sacral segment. If the lesion is above S2 or S3, what happens? Above the sacral, that we call it as a automatic bladder. So it is otherwise called upper motor neuron bladder or spastic bladder or reflex bladder. Micturition center எங்க இருக்குன்னா S2 S3 அந்த செக்மெண்ட்ல இருக்கு. ஸோ இப்போ லீஷன் spinal cord lesion இந்த sacral micturition centerக்கு மேல அப்படின்னா நம்ம அதை எப்படி புரிஞ்சுக்கணும்? Upper motor neuron bladder or spastic bladder or a reflex bladder. So what is option B is autonomous. It is a if the lesion is below, so below the sacral segment, that we call it as a lower motor neuron bladder or flaccid bladder or non-reflex bladder. Okay, so the next one option is a detrusor sphincter and flaccid sphincters. See, I think you know that everyone know about this urinary bladder. Yes. So this is a bladder is made up of detrusor muscle and we have a urethral sphincter. So what is if the synergic action of detrusor and urethral sphincter is important? If the detrusor muscle oda vela enna appadina bladder contract பண்ணி urine கீழ வரும். Urethral sphincter it is relaxed ஆகி voiding of urine நடக்கணும். So இதுதான் வந்து remaining options ஓட explanation flaccid sphincter. So இப்போ இந்த கிரிட் மேனுவர் நம்ம எதுக்காக யூஸ் பண்ணுவோம் அப்படின்னு பாத்தீங்க அப்படின்னா ஆட்டோமேட்டிக் பிளாடர் அப்படின்னா எப்படி இருக்கும்? அப்பர் மோட்டார் நியூரான் பிளாடர் ஆர் ஸ்பாஸ்டிக்கா பிளாடர் ரொம்ப டைட்டா ஸ்பாஸ்டிக்கா டோனிக்லி ரொம்ப கண்ட்ராக்டடா இருக்கும். கொஞ்சம் யூரின் ஃபில் ஆனாவே அவங்களுக்கு ஒரு அர்ஜென்சி அந்த ஃப்ரீக்வன்சி அந்த இன்கான்டினன்ஸ் என்ற சென்ஸ் இருக்கும். ஸோ அதுக்கு அடுத்து அட்டானமஸ் பிளாடர் அப்படின்னா அது ஒரு மாதிரி ஃபிளாபியா ஃபிளாசிடா இருக்கும். நிறைய யூரின் ஹோல்ட் பண்ணாலுமே ஸோ அவங்களால என்ன பண்ண முடியாது? void பண்ண முடியாது. ஸோ அப்போ the grid maneuver அப்படின்றது என்ன அப்படின்னா we give it like abdominal pressure to facilitate a voiding of urine. Yes, so we discuss let me see the answer. So autonomous bladder. So autonomous bladder என்ன இருக்கும்னா ஒரு மாதிரி flaccid இருக்கும். filling ஆனாலுமே அது void பண்ண முடியாது. ஸோ அதுக்காக we give it downward compression. So abdominal pressure கொடுக்கிறோம். That is a grid maneuver. Next question, which of the following types of spinal cord injury would most likely result in paraplegic condition? The C4 level, option C, injury at L2 level, option D, injury at the T10 level. Take a while. So let me discuss the options. So injury at C7 level means sparing of C3, C4 and C5, that involvement of forearm and wrist. C7 level injury ஆச்சு அப்படின்னா only quadriplegia or quadriparesis இருக்கும், depending upon the complete or incomplete spinal cord injury. So இதுல எந்த மசில் இன்வால்மெண்ட் இருக்கும் அப்படின்னா forearm அந்த hand muscles மட்டும்தான் இன்வால்மெண்ட் இருக்கும். இதுல respiratory muscle is spared, எந்த இன்வால்மெண்ட்டும் இருக்காது. So at the level of C4 அப்படின்னா இன்ஜுரி இருந்தது அப்படின்னா what is it at? So it is a phrenic nerve it innervated to this diaphragm. So கண்டிப்பா என்ன இருக்கும், பேஷண்ட்டுக்கு ரெஸ்பிரேஷன் வென்டிலேஷன்ல தான் இருப்பாங்க, எஃபெக்டிவா கஃப் பண்ண முடியாது. ஸோ பேஷண்ட் ஜென்ரலா குவாட்ரிபாரசிஸ் ஆர் ப்ளீஜியால இருப்பாங்க. ஆப்ஷன் சி இன்ஜுரி அட் த L2 லெவல் அப்படின்னா இட் இஸ் லோவர் அப்டாமன் இன்வால்வ் இருக்காது. ஸோ தைல பாதி பார்ட் இஸ் அ லோவர் லெக் இன்வால்வ்மெண்ட் தான் அதிகமா இருக்கும். ஸோ ஆப்ஷன் டி இன்ஜுரி அட் த T10 லெவல் அப்படின்னா இட் இஸ் இம்பார்ட்டன்ட். ஸோ லோவர் அப்டாமன் is gluteus maximus and thigh muscles. It is a purely paraplegic condition. So which of the following types of spinal cord injury would most likely result in paraplegic condition means the answer is injury at T10 level. Next question, 17th question. Basilar artery, that is a paramedian branch syndrome except. So I think it is a repeater and possible question. Option A, Millard-Gupler syndrome. Option B, Benedict syndrome. Option C, Locked-in syndrome. Option D, Wernicke's syndrome. So take a time, guess the answer. So let me discuss the options. Millard-Gupler syndrome, that basilar artery will supply the brainstem structures. The Millard-Gupler syndrome is involvement of 6th and 7th cranial nerve, which means ipsilateral facial weakness and contralateral hemiplegia. Yes, nothing but the involvement of cranial nerve. So the cranial nerve, rendu cranial nerve involved ஆயிருக்கு. So அதோட சேர்த்து contralateral hemiplegia, it is a Millard-Gupler syndrome. So Benedict syndrome, same, that involvement of 3rd cranial nerve plus contralateral tremor and contralateral hemiplegia இருக்கும். So at the level of pons. What is the Locked-in syndrome? Simply for it is a patient's a presentation of quadriplegia mari irpanga. So the eye muscle and mouth, so muscles of eye and mouth is spared. So eppadi irpanga appadina coma la quadriparesis அந்த மாதிரி தான் இருப்பாங்க. ஸோ இந்த ஐ அண்ட் மவுத் அந்த இது மட்டும் ஸ்பேடாக இருக்கும், ஐ மசில்ஸ் மட்டும் இருக்கும், கண்ணை நல்லா முடிச்சு பார்த்துட்டு இருப்பாங்க. நெக்ஸ்ட் ஒன் இஸ் Wernicke's syndrome. So Wernicke's syndrome is typically the thiamine deficiency. ஸோ அந்த thiamine deficiencyனால அவங்களுக்கு வந்து Wernicke presentation இருக்கும். ஸோ எப்படி இருக்கும்னா சேம் ஹெமிப்ளீஜியா இருக்கும். ஸோ அண்ட் அக்குலார் மோஷன்ல சேஞ்சஸ் இருக்கும். எதனால வருது அப்படின்னா, ஸோ தைமினோட ரோல் என்ன அப்படின்னா, இட் வில் கிவ் இட் எனர்ஜி. ஸோ அந்த குளுக்கோஸ் வந்து கன்வெர்ட் டு எனர்ஜியா மாத்திரதான் இந்த Wernicke syndrome. யாருக்கு வரும்னா, இப்போ ட்ரங்கர்ஸ் யூஸ்வலா ரொம்ப ட்ரங்கர்ஸா இருக்காங்க அப்படின்னா, ஸோ அந்த deficiency of thiamine இருக்கிறதுனால same ocular and hemiplegic symptoms இருக்கும். That one is Basilar paramedian branch syndrome. All of us, this is Millard-Gubler, also the Basilar, the paramedian branch will supply that pontine, and Benedict's also the supplied by basilar artery. Locked-in syndrome, these are all a syndrome which is related to basilar artery. The vernix is a deficiency of vitamins, so that is a different, that is odd one. The answer is the vernix syndrome. Next question. Hermatis sign is a feature of which condition? So it is a sign. Option A, multiple sclerosis. Option B, motor neuron disease. Option C, spinal muscular atrophy. Option D, Guillain-Barré syndrome. So disease, we call it as. These are all options. It is a sign. Take a look. So let me discuss the option. Motor neuron disease, motor neuron alone involved, which means the presentation of weakness, wasting, which means upper motor and lower motor neuron symptoms da irukum. Spinal muscular atrophy is a genetic disorder. It is a genetic autosomal, and the dystrophin oda logai adanala varudhu. GBS, I think we are aware about this. It is a post-infectious polyneuropathy. Multiple sclerosis, it is a demyelinating sclerotic patches over a central nervous system. It is a sign. If we examine a patient, flex your neck, the patient's extremity, especially the upper limb, feel like a shock-like sensation. That is a Hermatis sign. We observe the sign in multiple sclerosis. Next, the skeleton hand seeing. What is the skeleton or gutter hand? Pseudo-bulbar palsy, option A. Option B, progressive bulbar palsy. Option C, progressive muscular atrophy. Option D, primary lateral sclerosis. Have a look. Let me discuss the options. These are all motor neuron disease. I have to tell one thing. The name itself, motor neuron disease, there is no sensory involvement, there is no bladder, there is no ocular involvement. Motor nuclei of different region of brain, especially the primary lateral sclerosis is a cortico-spinal tract motor nuclei will involved. Yes, and progressive bulbar and pseudo-bulbar cranial motor nuclei will involved. So what is the progressive muscular atrophy? It's nothing, anterior horn cell of spinal cord. I think we are very that lower motor neuron lesion. So below the nuclei, below the anterior horn cell at the level, the patient have a weakness, wasting, reduced, diminished reflexes. These are a presentation of lower motor neuron lesion. Here, the progressive muscular atrophy, the patient have the weakness or wasting of hand muscle, indrasy, that is a dorsal indrasy weakness. How it could be? It is a skeleton. வெறும் குச்சி மாதிரி எலும்பு மட்டும் இருக்கிற மாதிரி இருக்கும். So that is a classical presentation of progressive muscular atrophy. Option, so that's the answer. Progressive muscular atrophy. So the last question, PROF agnosia. Yes. So the option, object, inability to identify the familiar faces, inability to interpret the visual stimuli, and inability to remember the appropriate color. So agnosia abdina enna abdina, so we have a discussion. Familiar object, நம்ம கையில என்ன வச்சிருக்கோம் அப்படின்னா என்ன ஆப்ஜெக்ட் வச்சிருக்கோம்னு they don't know that texture, so அதை ரெகக்னைஸ் பண்ண முடியாது. ஸோ அதுக்கு பேர் தான் அக்னோஷியான்னு சொல்லுவோம். ஸோ திஸ் அ டேர்ம் இஸ் prosopagnosia அப்படின்னா என்ன அப்படின்னா inability to identify the familiar faces. That is the answer of this question. What is the option C is interrupt the interpretation of visual stimuli. அவங்க அதுக்கு விஷுவல் அக்னோஷியான்னு சொல்லுவாங்க. பார்த்து ஒரு பொருள் நம்ம டிஃப்ரெண்ட் டைப் ஆஃப் ஆப்ஜெக்ட்ஸ் கொடுக்குறோம் பாருங்க அப்படின்னு சொன்னா ஸோ இது என்ன ஆப்ஜெக்ட்னு அவங்களால டிஸ்டிங்விஷ் பண்ண முடியாது. ஆப்ஷன் டி inability to remember the appropriate color, that we call it as a color agnosia. What is the prosopagnosia அப்படின்னா answer is inability to identify the familiar faces. Thank you so much for everyone. So I give it all the best to all for forthcoming examination. Thank you so much.